Hi, this is your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of Touro University. This is webinar number 25, 90 Minutes, the medical magazine of the web, and welcome back. We have been following a format for our last few webinars of expanding our scope of interest beyond simply COVID-19 and representing ourselves as a general interest medical magazine of the web to tell you not only about COVID, but about a lot of other medical topics in the news. We've got a good lineup for you this afternoon. And as I often say, I've got some old friends for you and I've got some new friends for you. I've invited back an old friend, Dr. Karen Murray, obstetrician gynecologist, to talk to us about the topic, is there actually a medical management of menopause? And if so, what is it? Next up, in response to a request, we've got your fan favorite. Yes, Dr. Marisa Montecalvo is back. And the reason Dr. Montecalvo is back is because a couple of weeks ago, I went for my regular checkup with my internist, and I said to her, well, I've had the COVID vaccines and all the boosters and the bivalent vaccine. What now? And my internist says, I don't know. I guess we'll have to wait and see. And then the FDA said, well, we're supposed to be getting yet more boosters if you're over 65 and or you have immunocompromised. So Dr. Montecalvo is back to tell us, do you need another shot? If so, what kind of shot should you get? And what are the criteria for who should get it? At our last webinar, we had a presentation about hip fractures in the elderly, and there was a discussion in the Q&A period about whether the average person is supposed to be taking vitamin D. And I thought it would be good to learn some more about that. So I've invited the Chief of Endocrinology at Westchester Medical Center and New York Medical College, Dr. Michael Goldberg, to join us to teach us whether the average person should or shouldn't be getting their vitamin D measured and taking vitamin D. And finally, there's been a story in the news recently about the citizens of Livingston, New Jersey, getting letters saying there's a chemical in your water supply and there's too much of it, and it's a contaminant, and we're going to monitor it. And then there have been politicians saying, don't worry, you can drink the water, and other people are not so sure you can drink the water. So we've invited someone who you haven't met before, Dr. Amy Brown. Dr. Brown's an expert on water supply, water contaminants, and she's going to teach us all about what's going on with the water supply of Livingston, New Jersey, and not only Livingston, New Jersey, but what all of us should be concerned about new contaminants being found in public water supplies. Now, as always, if you have any questions for any members of our panel today, go ahead and type your questions in the Q&A box on the screen. We'll be monitoring them, and we'll get to as many as we can during the Q&A period after all of our presenters speak. Also, if you want to get your continuing medical education credit, I'll be back with you in between the speakers to tell you how to get your CME credit. And also, I'll be back intermittently to tell you how you can support these webinars. Thanks for joining us once again. We hope you enjoy webinar number 25, and let's get started with Dr. Karen Murray.
Hi, good afternoon. I'm Karen Murray, an obstetrician gynecologist and the Associate Dean of the New York Medical College School of Medicine. Today, I'm here to give you some tips on managing menopause. I have no disclosures. Let's start with an overview of what is menopause. Menopause is a normal physiological event reflecting the loss of ovarian function. Studies have shown that by the year 2025, there'll be about 1.1 billion postmenopausal women in the world. This reflects the fact that we're living longer. The symptoms of menopause are usually recognized and diagnosed after having 12 months of amenorrhea. So this is really a retrospective diagnosis. The average age of menopause is about 51 and a half to 52. and with a range of 40 to 58. We also have induced menopause or premature menopause, which occurs when someone has had their ovaries removed or iatrogenic ablation of the ovarian function. There are two other diagnoses that we need to look at: primary ovarian insufficiency, as well as early menopause. What is primary ovarian insufficiency? That is loss of ovarian function that occurs in women who are under the age of 40, and that affects about 1% of the population. Early menopause are patients who are between the ages of 40 and 45, and that affects about 5% of women. So how do we diagnose menopause? As I stated earlier, there are no tests that are needed to typically diagnose menopause. Menopause is usually a retrospective diagnosis that's made after women have gone through that transition period that can last up to 18 months. Under certain circumstances, your provider may do some blood tests to check your follicle-stimulating hormone or estrogen level. So an elevated FSH and a decreased estrogen is reflective of menopause, or they may check your thyroid functions, which can also mimic the symptoms of menopause. We also have on the market some home kits to test for FSH. Menopause has a varied different symptoms that can occur, as seen here. Some of the most common ones are the vasomotor instability that occurs and is known as hot flushes. Hot flushes affect about 75% of American women, and it's usually flush of the face, the neck, and the chest. You can sometimes get a small rise in body temperature, and it can also occur when someone's fatigued or tired. That's the most common times that they can occur. There are also psychological symptoms, such as mood swings, depression, trouble concentrating, and also urogenital symptoms. Estrogen is the urogenital tissue is very sensitive to estrogen. And so therefore, decrease in estrogen can cause vaginal thinning or shortening, irritation of the urethra, and sometimes frequent UTIs can occur at that time. Some of the other long-term risk factors are coronary artery disease, as estrogen has a positive reaction on the cardiovascular system in that it increases HDL, decreases LDL, and thereby reduces the risk of cardiovascular disease. Osteoporosis. Again, estrogen helps to keep bones stable, and a loss of estrogen will lead to osteoporosis. Cognitive function can also be affected with a loss of estrogen, as high estrogen helps to increase the blood flow to the brain, which then increases the growth of neurogenic dendritic growth, which can then increase neurotransmitter production. Some studies have shown that patients on HRTs tend to live a little bit longer than those who do not take hormone replacement therapy. Some of the other symptoms that can occur with menopause is abnormal bleeding. Irregular vaginal bleeding may be a normal part of menopause, or it could be a sign of another problem. So if you have vaginal bleeding that occurs more often than every 3 weeks, if you have excessive menstrual bleeding, spotting in between your periods, or bleeding after you've had your 12 months of amenorrhea, you should see your clinician, who may want to do further testing. Another thing that comes up with menopause is fertility. We all know that fertility decreases with age, but until you've gone through menopause, there is still a risk of getting pregnant. Once you've gone through menopause and you've had those 12 months of amenorrhea, the chances of getting pregnant are very slim to none. If you're taking birth control, it's always, when do I stop my birth control? So if you have some type of hormonal contraception, speak with your clinician and see when is the best time for you to stop your birth control. If you have an IUD in place, you can also, if you have an IUD in place, you can either wait until it's time for that IUD to be changed, or wait until the average age of menopause to change your IUD or remove your IUD. The North American Menopause Society has made some recommendations for the clinical care of women in their midlife cycle. They recommend menopausal counseling for all women going through midlife. That counseling should include discussion of physiological changes that are about to happen, assessments of menopause-related symptoms and treatment options, screening recommendations, risk reduction strategies and psychological issues, as well as making an informed decision about what needs to happen to these women as they go through this midlife change. What are the treatments for menopause? Menopause requires no medical treatment. What we focus on is relieving the symptoms and preventing or managing the chronic conditions that can occur with aging. Some of the treatment options we have are lifestyle modification, hormonal therapy, including vaginal estrogens, low-dose antidepressants, gabapentin, clonidine, and medications to prevent or treat osteoporosis. So when we talk about lifestyle modification, we talk about cooling the hot flush. So that's about wearing layers. So if you're too hot, you take some layers off. If you get too cold, you put some layers back on. Decrease in vaginal discomfort by using vaginal lubricants. Sleeping, making sure we get enough sleep. Eating a balanced diet, as well as exercise. So we're looking to eat foods that are rich in calcium and vitamin D to help with bone. We want to hydrate. We want to try to maintain a healthy diet, eat foods that are high in phytoestrogens, take natural supplements, and avoid the triggers such as alcohol. Now, I know this slide has a lot of, it's kind of busy, but I thought it was important to have so we can kind of compare some of the lifestyle modifications to how it's going to help us. So for instance, a diet high in fiber as well as cardiovascular exercise helps to decrease your cardiovascular risk. A diet low in fat, as well as weight-bearing exercises, helps to decrease our cholesterol profile, therefore helping us in that way. Smoking cessation will also help to decrease cardiovascular disease, as well as getting a lot of sunlight, making sure we're going for walks. That helps our depressive mood, as well as increases our intake of vitamin D, which then will help with osteoporosis. Hormone therapy is the most effective treatment for relieving hot flushes. The recommendation is the lowest dose for the shortest period of time. It has, if you still have a uterus and you're going to have a hormonal therapy, you should also add progesterone to that hormonal therapy for protection of the uterus. Estrogen can also help to prevent bone loss. Keep in mind, long-term use of estrogen therapy does have some cardiovascular and breast cancer risk. So that, again, you have to speak with your clinician if you decide that you need hormone replacement therapy. There are many different types of hormone replacement therapy. Between you and your provider, you choose the one that works best for you. There are some contraindications, however, to hormone replacement therapy. There are absolute contraindications such as estrogen-responsive breast cancer, endometrial cancer, abnormal or undiagnosed vaginal bleeding, thromboembolic disease, as well as a history of malignant melanoma, are all absolute contraindications. There are some relative contraindications listed here. And again, you can speak with your clinician to see if the risks outweigh the benefits or the benefits outweigh the risks. There are a few other medications that I touched on. Low-dose antidepressants such as SSRIs may help with mood disorders in menopause. Gabapentin, which is a seizure disorder medication, has also been shown to improve hot flushes, particularly nighttime hot flushes. Clonidine, whether in the pill form or patch, which is a blood pressure medication, can also help to relieve your hot flushes. And again, taking enough vitamin D will help to strengthen our bones. There has been some research done on the role of androgens in postmenopausal women. We know that the ovaries and the adrenal glands make androgens, which can help with musculoskeletal, nervous, hepatic, and vascular tissues. Androgens have also been shown to increase your libido and have a protective effect on bone mass. However, androgens with HRT are really not complementary to our cholesterol profile. And so if you're someone who already has established cardiac disease or at high risk for cardiac disease, then maybe that's not that would not be of benefit to you. Try something else. The other thing is the adverse effects of androgens, such as virilization, can also occur. Alternative medications that have been shown to help Again, there's not a lot of scientific evidence for most of these medications, but plant estrogens such as phytoestrogens have been shown to be beneficial in the relief of hot flushes. Studies have shown that women living in Asian countries, which has a diet high in phytoestrogens, are less likely to suffer from hot flushes. There are also bioidentical hormones that come in the form of estrogen and progesterone. Again, these are all plant-based, have been shown to have some effect on the symptoms of menopause. So in summary, many women will spend a third of their lifetime after menopause. Currently, HRT is the primary treatment for the symptoms of both short-term and long-term effects in menopause. There are other medications such as bisphosphonate and calcitonin that can help with the treatment of osteoporosis and heart disease. In addition, complementary stuff such as vitamins, herbal treatments, exercise, and lifestyle modification can also help to relieve many of the symptoms associated with menopause. Again, the recommendation is an individualized treatment plan. Speak with your clinician and see what works best for you in your specific needs. Thank you very much.
Hello again, this is your host, Dr. Edward Halperin, to tell those of you who want continuing medical education credit how to get it. We have two choices for you. You can text message the acronym 60EVES, 60 E's. Text message that to 828-295-1144. If you do that, you're going to get a response back, and it will tell you how to fill out your satisfaction questionnaire and how to get your CME credit. If you don't want to do that, then you can get out your handheld device and scan the QR code, and it will automatically take you to the website. Once again, you're going to have to put in the code 60EVES, and then it will walk you through filling out the questionnaire and getting your CME credit. Now, whatever you do, please remember to do it by noon on Monday, May 15th. Otherwise, it will expire. So I suggest you take a screenshot, you write this down, you go ahead and make some notes so that you get it done promptly and don't lose your chance to get the CME credit. As always, if you have any questions for any of our panelists, please go right ahead and type them in the Q&A box on the bottom of the screen, and we'll get to as many of them as possible in the QA part of our program. Now let's get back to our speakers.
Good afternoon. I'm Marisa Montecalvo, and I'm speaking on COVID vaccines and boosters. And if you've had your vaccine and your booster, what next? I have no conflicts of interest to disclose. For those receiving CME, the learning objectives are to understand the changes in vaccination since the initial approvals and the current options regarding boosters, and some of the issues regarding the duration of vaccine immunity that lead to the recommendations. So I just want to take a glance back to 3 years ago. Seems surreal, everything that happened. This was a testing hospitalization tent in northern Italy, St. Peter's Square on Easter 2020, and the New Jersey Turnpike, 5 o'clock on a Friday, 2020. We had 100,000 deaths in the United States by May 24th. This is a weekly graph of deaths due to COVID-19. And here is the beginning of vaccination, which took about 4 to 6 months to really get distributed. Deaths went down, but then we had the more transmissible Delta variant, which had some capacity to escape the immunity of vaccination, followed by the Omicron variant with similar issues of breakthrough infections. So I just want to give you a brief history on the vaccines. If we start with primary vaccination, which is your initial series, we began with 2 messenger RNA vaccines being approved within a week at the end of 2020, followed by the vector vaccine, and then the messenger RNA vaccines were expanded to younger age groups. In July of 2022, we saw yet another new vaccine, which is the protein subunit vaccine, Novavax. And as of last month now, for those who are unvaccinated, we're actually using the bivalent vaccine, which had initially been developed for the booster. For those who are immunosuppressed, there's always been a bit of a different schedule because, back in 2021, it became clear that they would need a third dose even before boosters were recommended. Boosters first were recommended in the fall of 2021, initially for select groups at high risk at 5 months after primary vaccination, unless you had received the vector vaccine, in which case it was at 2 months. But with all the breakthrough infections, by December, boosters were recommended for all persons over 18 years of age. And a second booster for those over 50 or who were immunocompromised in the spring of last year. And then at the end of last summer, we saw the development of the bivalent vaccine. And because that is different, it has both the ancestral strain and the Omicron strain that was recommended 2 months after the last dose. So as of last month, we have these vaccines available, just the bivalent and the protein subunit. We had the vector vaccine, but as of last week, that is no longer available because the doses in the United States are now expired. So what has happened with all of this is a simplification of the products in use, that with all of these changes over the last year and a half, 2 years, there were many different vaccine formulations. Now we just have the bivalent, irrespective of whether it's primary or boosting, and the protein subunit vaccine. So if you've had your vaccine and your booster, where are you at? Well, it depends on what booster you've had. If the booster you received was the original monovalent vaccine, then you are to receive a bivalent booster. If you've already received the bivalent booster, then right now there's nothing authorized for you. For those who do not want to receive a messenger RNA vaccine, you can receive a booster with Novavax. Now, how about if you've had your vaccine and your booster and your bivalent booster, then what? Well, there is a recommendation that has recently come out that for those at high risk of severe disease, you could receive yet another bivalent booster after 4 months. And certainly those who are immunosuppressed are always on a vaccination schedule with smaller intervals and to receive another booster. But things are definitely moving toward an annual vaccine. So why is that? When we look at the efficacy of these vaccines, its efficacy is tied very closely to time since last vaccination for certain outcomes. So when we look at severe outcomes like hospitalization and death, these vaccines hold up very well at 4 to 6 months. You've got 80 to 90% efficacy for both of these. But when we look at just transmission or symptomatic disease, we know there's a lot of breakthrough infection. And really protection is best just in the 4 to 6 weeks after receipt of the vaccine. There are household studies coming out indicating some benefit toward reducing transmission. But it is because of this that we are often in a situation of relatively frequent boosters. So together with that, there are two confounding issues. Variants. The variants with this virus allow some immune escape. So these are all the different variants in the upper graph ending with Omicron at the end of 2022. And now there is a new variant in circulation in the world, the XBB.1.5 variant. And we will see how that looks over time. And along with that, we also know that in the winter, we often see a peak. So this was Omicron, but even this winter, which was mild, there was an increase in cases. So all of that together is pointing toward an annual vaccine. So in conclusion, a bivalent messenger RNA vaccine is currently recommended for all persons, with an option for the protein subunit vaccine for those who can't receive a messenger RNA vaccine. If you've received your bivalent dose, a further dose could be an option for those at high risk of severe disease, and certainly those who are immunocompromised. And it's looking like we will be having an annual vaccine, that exactly which vaccine will be somewhat dependent on the variants. I'd like to conclude with just these resources, which are relatively available through the web. And I just want to say that today is the end of the public health emergency. It is supposed to not change the distribution of vaccines or the cost to any individual, and some of that is available here on this website. And also at 2 o'clock today, there is a CDC call going into further detail about clinical issues in relation to the bivalent vaccine and its use for both primary vaccination and a booster. Thanks very much. I look forward to your questions.
Hi again, this is your host, Dr. Edward Halperin, explaining how you might give back to New York Medical College, because programs like we're putting on today and research projects, which we talk about, require time and effort and money. By making a tax-deductible gift, your donation will help offset our costs. Now, great things are happening in New York Medical College. We hope you'll be a part of it. You can visit a website, www.nymc.edu/give, to make a donation. Other ways you can make a donation to support this webinar is we have real people who answer the telephone. You could call 914-594-2720, and they'll be more than happy to take your credit card information over the phone if you'd like to make a tax-deductible donation. As I said, you can use this website, www.nymc.edu/give, to make a donation to support this webinar and our research. Or if you believe in pens and checks, we take those too. You can make a check out to New York Medical College, write on the memo line of the check, support for the webinar, and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us. Thanks for supporting these programs. Remember, if you want to ask a question of any of our panelists, go ahead and type it in the Q&A box on your screen. We'll get to as many as possible during the Q&A part of the program. Stay safe, everyone. Stay healthy, and let's get back to our show.
Hi, my name is Michael Goldberg. I'm a member of the Division of Endocrinology at Westchester Medical Center, and it's my pleasure to participate in today's program. As Dr. Halperin mentioned, I've been asked to address these two questions. Should everyone be screened for vitamin D deficiency? And should everyone with low vitamin D levels take vitamin D supplements? I have nothing to disclose. So to begin with, there's no question that the number of vitamin D tests performed each year in the United States has skyrocketed. In 2014, the government reviewed the trends in laboratory test volumes among Medicare beneficiaries between the years 2000 and 2010. This figure shows the results for a subset of nutritional and immunologic tests, including vitamin D in the blue diamonds. And you can see that starting around 20 years ago in 2003, the volume of vitamin D testing began to increase exponentially. Moving forward a few years, this report ranked the 25 lab tests for which Medicare made the highest total payments in the year 2016. Vitamin D came in at number 5, edged out only by TSH, Comprehensive Chemistry Panel, CBC, and Lipid Panel. In fact, these top 6 tests together accounted for more than 1/3 of Medicare's overall payments for all lab tests in the year 2016. So why are doctors ordering so many vitamin D tests? Well, I believe part of the reason is that Dr. Google has become one of the most trusted physicians in America. When I Googled vitamin D deficiency recently, the results would lead one to believe that low vitamin D levels may be the explanation for just about every common ailment that many folks face on a daily basis. Now, while the evidence supporting a connection between vitamin D deficiency and any of these particular items is slim to non-existent, over the past 20 years, there have been a large number of studies in the medical literature suggesting a potential link between vitamin D levels and many serious medical conditions. Before we look at the evidence for or against routine vitamin D testing, let's take a minute to review the role of vitamin D in general health. Vitamin D is a steroid hormone that is synthesized in the skin, triggered by ultraviolet rays from sunlight. Vitamin D may also be obtained through the diet, specifically oily fish like salmon or fortified milks and cereals, or from dietary supplements. The main physiologic actions of vitamin D are to promote the absorption of dietary calcium in the GI tract and reduce urinary excretion of calcium and phosphorus. The net effect of these actions is to ensure adequate supplies of calcium and phosphorus for maintaining healthy bones, a process known as bone mineralization. Without sufficient vitamin D, bones are inadequately mineralized. And if there is severe vitamin D deficiency in childhood while the growth plates are still open, the result is rickets, as shown in these photographs. If the vitamin D deficiency occurs in adulthood, once bone growth is complete, the result is osteomalacia, which can lead to bone pain and increased risk for bone fractures. Now, experts still have not definitively identified the blood levels of vitamin D that are associated with rickets, but the U.S. Food and Nutrition Board put forth the following suggestions in 2010. A level below 12 was felt to put one at high risk for clinically relevant sequelae like rickets or osteomalacia. Of interest, when the NHANES survey data were reviewed for the years 2011 to 2014, about 5% of the US population fell into this category of vitamin D deficiency. A level above 20 was defined as generally adequate for bone health, and then the gray zone in between was considered inadequate or insufficient. On the other hand, once the level exceeds 50 to 60, we start to get concerned about the risks for vitamin D toxicity, which can manifest as higher than normal blood calcium levels and higher than normal urine calcium levels, which could lead to kidney stones. Certain groups are at high risk for vitamin D deficiency, and these are the individuals for whom screening may be beneficial. The first group reflects people who obtain less vitamin D from sun exposure, either by using sunscreen, by being confined indoors, or from having greater amounts of melanin in the skin, which reduces the skin's ability to produce vitamin D from sunlight. In addition, the skin begins to synthesize vitamin D less efficiently around age 70. Because vitamin D is a fat-soluble vitamin, any conditions characterized by fat malabsorption, such as celiac disease or inflammatory bowel disease, also increase the risk of vitamin D deficiency. Obesity is felt to be associated with D deficiency due to greater amounts of the vitamin being sequestered within the excess subcutaneous fat. And finally, with advanced liver or kidney disease, the inert form of vitamin D cannot be effectively hydroxylated to become the active form. Now, vitamin D also modulates many extraskeletal processes in the body, and observational studies have shown inverse associations between blood levels of vitamin D and the incidence of the diseases listed here. However, it's been very difficult to prove a causal relationship. In addition, the results of clinical trials of vitamin D supplementation, of which there have been many, have not consistently demonstrated reductions in the risk for these diseases. As an example, let's look at VITAL, which is a randomized controlled trial that was designed to determine whether supplementation with vitamin D reduces the risk of cancer or cardiovascular disease. This trial was sponsored by the NIH and recruited men age 50 and older and women 55 and older. Altogether, almost 26,000 participants were randomized to receive vitamin D at a dose of 2,000 units daily or placebo. The average age in the study was 67. About half of the participants were female, 71% were non-Hispanic whites, and 20% identified as Black. The median follow-up was 5.3 years, and as you can see in these two Kaplan-Meier curves, there were no significant differences between those who received vitamin D and those who received placebo in the incidence of cancer, shown in panel A, or major cardiovascular events in panel B. So even though many observational studies had shown an association between low vitamin D levels and the risk for cancer and cardiovascular disease, This large randomized trial showed that vitamin D supplementation did not reduce those risks. There have been several sub-studies published from the VITAL trial, and I thought this one, which appeared in the New England Journal last summer, was of particular interest. Here, the rates of bone fractures in the two study groups were compared. And here again, there was no significant difference between the two groups in terms of the measured endpoint, which was the incidence of new fractures. In 2021, the U.S. Preventive Services Task Force published an updated systematic review to synthesize the best available evidence from studies like VITAL regarding the health benefits of vitamin D deficiency screening and treatment. The task force reviewed the medical literature and selected for articles for review if they included asymptomatic adults without known vitamin D deficiency and without any underlying disorders of bone metabolism like osteoporosis. And these were the 4 key questions that were looked at. It turns out that there was a grand total of 0 articles in the literature that directly addressed the benefits or harms of screening for vitamin D deficiency. But as I mentioned earlier, there have been many studies looking at vitamin D supplementation and health outcomes. And the results of those studies are summarized in this table. They were remarkably consistent. Treatment of vitamin D deficiency had no benefit on the outcomes of mortality, bone fractures, diabetes, cancer, cardiovascular events, falls, and depression. In terms of part B of the question, do the results vary among patient subpopulations at higher risk for vitamin D deficiency or vary by race or ethnicity? There were not enough data to support a meaningful comparison of the results among such subpopulations. Of the 36 studies that were analyzed to assess any harms associated with vitamin D supplementation, overall, the incidence of adverse events was similar between the treatment and control groups. Specifically looking at kidney stones, there was only 1 case in the 10 studies that reported the incidence of that adverse event. So based on a low strength of evidence, there were felt to be no harms of treatment of vitamin D deficiency. So in a companion piece to the systematic review, the USPSTF summarized its recommendation regarding screening for vitamin D deficiency by stating that the evidence is insufficient to assess the balance of benefits and harms of screening, and more research is needed. Of note, this recommendation was identical to the one that the task force had previously published in 2015. So in closing, I'd just like to read the recommendations that appear on the website Choosing Wisely. This is an organization that helps patients understand which medical tests and treatments are supported by clinical evidence. And I think these recommendations provide a nice summary of what I've presented today. First of all, many people have low levels of vitamin D, but few have seriously low levels. Most of us don't need a vitamin D test. Even if you are at risk for other diseases like diabetes and heart disease, a vitamin D test isn't usually helpful. The test results are unlikely to change the advice from your doctor. It's much more important for you to make lifestyle changes first, to stop smoking, aim for a healthy weight, and be physically active. And like most other Americans, you should try to get enough vitamin D from sun and foods. Secondly, getting tests that you don't need often leads to treatments you don't need, or treatments that can even be harmful. For example, if you take too much vitamin D, it could damage your kidneys and other organs. One blood test for vitamin D does not cost much, but doctors are ordering tests more often than ever, and the vitamin D test is now the 5th most popular lab test for older adults. All of these tests add up. In 2015, Medicare spent $337 million on vitamin D tests for seniors, up from $323 million the year before. On that note, I'd like to thank you for attending today's webinar, and I look forward to addressing your questions during the Q&A period.
Good afternoon. My name is Dr. Amy Brown, and I'm a pediatric pulmonologist and children's environmental health specialist who has the pleasure to deliver this presentation titled Livingston, New Jersey recently joined the list of American cities where residents received warnings about contaminants in the water supply. How do we test and monitor public water supplies to see if they're safe? I have no significant conflicts of interest to disclose, and I am grateful to the grant support for the work that I do in children's environmental health. My learning objectives are for the audience to understand the public health principles that guide testing of municipal water supplies. I will describe why PFOA, a specific contaminant of concern that was cited in the violation of the 2022 Livingston Water Supply Report, is being frequently detected nationally. And finally, I will review health concerns from PFAS and PFOA chemicals and action steps for Livingston residents to reduce their exposure. So what is the public health rationale for testing our municipal water? Well, the first point is that we test our public water to ensure that it is safe and it is dependable for our residents to consume for drinking purposes. We identify contaminants of concern to human health within our water supply, and these include infectious agents, metals, wastewater contaminants, pesticides, and byproducts of industrial processes and chemicals. The information is provided to consumers, which reflects ongoing testing across several sites, and this is consolidated into an annual report. How we determine what levels to test and what our maximum levels are is provided by the federally funded agency, the Environmental Protection Agency, as well as the state. And so why we're here today is to talk about the Livingston Annual Water Quality Report. This report evaluated 28 contaminants of concern across many of these several broad categories. And in this report, which is available on the website from Livingston, shows that there is a violation for elevated levels of perfluorooctanoic acid, or PFOA. And this is highlighted in yellow from the report, as you can see from the snip right here. So what are perfluorinated chemicals? So PFOA in particular falls into the family of PFAS chemicals, which stands for per and polyfluoroalkyl substances. These are man-made forever chemicals. And they're termed forever chemicals because they persist in the environment for a long time. And they're also very difficult for the human body to break down. They were first manufactured in the 1940s for their nonstick properties. And over 80 years later, these chemicals are ubiquitously found in the environment. And we'll talk about human health exposure, but unfortunately, most of the population has had some exposure to this family of chemicals. These few pictures on the bottom of the screen depict where we find PFAS in our environment. Again, I mentioned that PFAS chemicals are known for their nonstick properties. So if you go around the wheel from the bottom, you can see that nonstick cookware, various paints, pesticide exposure, shampoos and personal care products, photography products, firefighting foams, stain-resistant products, and in particular fast food packaging have high sources of PFAS exposure that can interact with human health. Many of these will contaminate the environment through whether it's industrial processing and or personal consumption. You can see in the second diagram, which is from the New Jersey Department of Environmental Conservation, that PFAS chemicals are found ubiquitously again in the environment. And what happens because they persist for a long time is they end up in our groundwater supply, as shown by this diagram, and then in our municipal water, which is now being tested for the presence of a variety of these chemicals. Once it's in our water supply, we will ingest it and drink it. And you can see over here from the third diagram that there are many sources and ways in which we can interact with PFAS from the environment. Ingestion is just one means of interacting with the environment, meaning the water that we drink or take in. Other means are inhalation, so from the air we breathe, which is less of a concern with PFAS chemicals, but still a significant source of environmental contamination, and via contact with our skin and personal care products. And I'll mention briefly the interaction of PFAS chemicals in pregnant women and a developing fetus as well. So why are we detecting this in the water supply in 2022? Well, as I mentioned, PFAS chemicals have been around since the 1940s, but it wasn't until 2016 that a maximum contaminant level of 70 parts per trillion was set by the Environmental Protection Agency. In 2020, many states, including the state of New Jersey, lowered that threshold for testing to 14 parts per trillion. And currently, in 2023, the EPA is evaluating an even lower level of 4 parts per trillion for a variety of chemicals found in this PFAS family. So the chemicals, in summary, have been around for many, many years. However, the testing did not start to take place until 2016. And more recently, as the threshold has gone down, there have been more violations noted in many countries, in many cities across the country, including Livingston. What are some of the health concerns from PFAS and PFOA chemicals? So we're just learning more and more, and there was a recent 2022 report from the National Academies of Science that elaborated on some of the health concerns. So health concerns in children and adults of what we know an association exists includes cholesterol levels and dyslipidemias, changes in liver enzymes, and decreased vaccine response in children. Now, these are very difficult to study because other exposures and genetic factors can also play a role, and it's a very active area of investigation from association to what we call causality of disease. Some health effects that are under investigation include endocrine disruption, developmental concerns, and inflammatory bowel disease, in particular ulcerative colitis. And this really has to do with the fact that ingestion is a major pathway for PFAS exposure and the exposure with our GI tract. As I mentioned, there's concern over observed pregnancy and neonatal complications, which can include premature birth and decreased infant birth weight. This can set up for a host of long-term diseases later in life. One of the active area investigations is also the long-term carcinogen effect of PFAS and PFOA chemicals, in particular increasing the risk for kidney or testicular cancer. So there are some key action steps that individuals and communities can take to reduce PFAS and PFOA exposure. One of the first steps is to be an informed consumer of the local water supply. The second step is to acknowledge the complex relationship of exposure to contaminants in water and human health outcomes. So I'm sure it took a moment to digest the slide that I just talked about, but we're still learning a lot more about those relationships. And so having that lens that an exposure in our water may cause human disease is important to know, but there's still a large complex relationship that is being worked out. And so as we learn more in the sciences and in the relationship to human health, we can take steps to ensure that we are reducing our own exposure to PFAS. So if the PFAS or PFOA levels in the local water supply, such as in Livingston, are elevated, residents can consider filtration of their drinking water. And this can be simple water pitcher filtration, something such as a Brita that uses an activated charcoal methodology, or an installed system. And these installed systems can include activated charcoal as well as something called reverse osmosis and other pathways for reduction. And this is really a personal decision. Some of these interventions can be quite costly, and many of these interventions are actually happening in the municipal water supply so that at the source, filtration is occurring before it enters into the home. And another option is to search for alternate sources for your drinking water, which will be also highlighted in the report, and can be an option, although it may be costly. And I would advocate that when switching to an alternate source of drinking water, that there is some level of testing or knowledge about the contaminants in that alternate water supply as well. And then the last thing that we can do, because we talked about the risk to human health, is reduce additional exposures to PFAS and PFOA chemicals outside of our water consumption. So making healthy decisions about the packaging in our food, the preparation of our food, and then thinking about also the personal care products we use and other sources of exposure. So thank you very much for your time. I know that this is a short presentation. There's a lot more to learn on PFAS. Thank you to my partners at the Children's Environmental Health Center of the Hudson Valley, a center of excellence at New York Medical College, our partners throughout the state, some of my wonderful mentors. And also, I just wanted to highlight that many of the action steps that I just mentioned are available through our Prescriptions for Prevention program, which is part of the Pediatric Environmental Health Specialty Units program. And again, they outline some of the things I mentioned here and are available for Livingston residents as well. Thank you very much for your time, and I look forward to hearing any feedback or answering any questions. Thank you.
Hi again, this is your host, Dr. Edward Halperin, with information as to how to get your CME credit. You've got two choices. You can text the code 60EVES, 60 EVES, to 828-295-1144. If you do that, you're going to get a response back telling you how to fill out your satisfaction questionnaire and how to get your CME credit. Or you can get out your handheld device and you can scan the QR code and it will take you to the correct website where once again, you'll type in 60EVES and you'll fill out the questionnaire about how satisfied you are with today's program. And you'll get information as to how to get your CME certificate. Whatever you do, please do it by noon on May 15th because it will expire by then. Remember, if you have questions for our panelists, please go ahead and type them into the Q&A box on your screen. We'll get to as many as possible during the Q&A part of our program, which is coming up next. So please make a note of this information if you want CME credit. And let's get started with the question and answer portion of today's program. Well, good afternoon. This is your host again, Dr. Edward Halperin. We've had about a dozen questions come in during the webinar so far. If you haven't typed your question in yet, go ahead and do it because I sure we'll have time for a few more than we've received so far, and I'll keep monitoring them as we go along. We're going to start with a question for Dr. Karen Murray and Dr. Michael Goldberg, if they could both unmute themselves and show up on the screen, please. Dr. Murray and Dr. Goldberg, our question is about hormone replacement therapy. And our questioner wants both of your perspectives on this. The question is, there's been an argument made that women need to be on hormone replacement therapy after menopause to reduce the risk of hip fracture. I remember the questioner writes, when I was in medical school being lectured by a senior obstetrician gynecologist who told us the mortality of an older woman after a hip fracture is very high. All my patients are on hormone replacement therapy. But Dr. Murray just said in her talk, give the lowest dose for the shortest period of time. Do the risks of hormone replacement therapy really outweigh the benefits? Let's take it in reverse alphabetical order, since Karen, they're questioning what you put in your slide. What do you think about the argument that a hip fracture is so devastating that it's worth the risks of hormone replacement therapy? And then we'll go to Dr. Goldberg.
So these recommendations were based on the most recent studies. Actually, the studies are pretty old right now. The studies came out 8 years ago. When I was in residency myself, we put everyone on hormone replacement therapy. We would take patients, they would remove their ovaries when they had a hysterectomy, and everybody would just be placed on hormone replacement therapy.
Dr. Goldberg, until we get Dr. Murray unfrozen, maybe you can pick up here.
Absolutely, thank you. Well, first, let me agree with a couple of the statements that were made by your supervisor. The hip fractures are devastating, and yes, hormone replacement therapy is remarkably beneficial in terms of bone health and reducing the risks of bone loss after menopause and fracture rates. But what changed, I believe, was very much related to the results of studies like the Women's Health Initiative that really gave us a better understanding of the risks associated with menopausal hormone therapy, as well as perhaps simultaneously the development of other classes of medications with positive effects on bone health, and medications that were in fact even superior to estrogen perhaps in reducing fracture risk. And so, yes, menopausal hormone therapy is no longer considered a first-line intervention to prevent or treat menopausal osteoporosis. We would instead choose from one of the many other classes of drugs that are available that do not carry the same kinds of potential risks for coronary disease, breast cancer, blood clots, and the like. So, yes, I believe that the consensus is that while if you are prescribed menopausal hormone therapy for the indications that Dr. Murray outlined, and it's helpful from a symptomatic point of view, you get the extra benefits of bone protection, but that wouldn't be an indication in and of itself to use hormone therapy at this point, based on the risks that are out there and the other options that are perhaps safer to choose from.
Now, thank you. To our listeners, it looks like Dr. Murray is suffering from a power surge, which has knocked out our computer. But since we've got Dr. Goldberg with us, we're going to keep him on the firing line for a few more questions. Our next questioner wants to talk about the table you showed. In the table, you seem to indicate that a vitamin D level greater than 20 was fine. But it looks to me, our questioner writes, like some of the laboratory companies, your level needs to be over 30. I suppose it's in the laboratory company's best interest to do things which will get you to get more tested more often, they write. I've even seen people say you need to drive your level over 50. So our questioner has, I guess, the most fundamental question. What's a normal vitamin D level and how come we don't know?
Yeah, it seems like it should be such a simple and straightforward question. And yet all these years later, there is no consensus agreement on that magic number. As a matter of fact, the table I showed was, again, from the government, specifically the Food and Nutrition Board, and it was put forth by the Institute of Medicine, and that goes back to 2011. But by no means are those numbers agreed upon by other professional societies. For example, my own colleagues in the Endocrine Society and the American Association of Clinical Endocrinology are both more aggressive. And in fact, some of those normal or suggested ranges that you see on your laboratory printouts come from those guidelines and not those from the Institute of Medicine. And that's why a level above 30 is recommended in many of those commercial lab reports. The endocrinologists are simply using different criteria to judge the level above which vitamin D levels are sufficient. It has a lot to do with whether we're looking at the measurement of other hormones, such as parathyroid hormone, and when the vitamin D level is low enough to have a noticeable effect on stimulating parathyroid hormone, which many endocrinologists feel should be the definition of deficiency. The Institute of Medicine was looking more at the level below which one would be at high risk for complications like rickets or osteomalacia. And there are many other criteria that have been put forth suggested to hang this definition on. But I had to pick one for my presentation, and that's the one I chose. But by no means is that an agreed upon number. 30 is in many cases the suggested number for sufficiency of vitamin D. And as far as the question about 50, that I don't believe carries a whole lot of weight from professional societies. I don't believe anyone has made a specific recommendation that a number that high should be targeted. I believe 30 is about as high a number you'll see suggested for most professional recommendations. Thanks for a great question, though.
Well, as you've been answering that question, someone's typed in, well, let's say you've got osteoporosis and you're taking calcium and vitamin D regularly. How often are you supposed to get your level checked?
Right, that's a great question. And there again, there is no evidence-based guideline to answer that question that I'm aware of. We know that if you are treating vitamin D deficiency with vitamin D supplementation, it's generally recommended to wait about 3 months before retesting the blood level of vitamin D to see the full effect of the supplementation. But in terms of how often to check in someone who is on vitamin D and calcium supplementation in the setting of, say, osteoporosis, my personal practice is to do it once or twice a year. But again, that's not based on, at least as far as I'm aware, any evidence-based recommendations. Thank you for that thought-provoking question.
Thank you. We're going to give you a rest. We've got some questions for Marisa Montecalvo, if she could join us. The questioner writes, Marisa, the newspaper tells me if you're over 65, you should be getting another COVID booster shot. You just said that. But 2 of my close in age cronies have already been told by their physicians, you've had enough boosters, you don't need to get another. Who are we supposed to believe, particularly since the recommendations keep changing. And when's enough enough? Or are we really going to be, as you suggest, on this every year?
Thank you for that thoughtful question, because that is the issue. So, so if you've already received a bivalent booster, whether to receive a second bivalent booster because you're over 65, and I assume not severely immune suppressed, is very much an individual decision. It's similar to what happened a year ago. Remember, we all got boosted with the original vaccine. And then around May, the issue came up. If you're over 50, maybe you should get one more booster, right? So it has to do with whether you really, really perceive yourself at some high risk. So some people chose to get that extra booster because they were traveling, in particular on a long flight, or would be traveling for several weeks. I think that as time has gone on and we've seen how the virus changes, and some of those changes result in some evasion of the immunity that is granted by the current vaccines, I think it's likely that there will be an annual vaccine, and the timing of that is likely to be in preparation for the late fall winter season, because rates tend to go up in the winter. Combination of variants that may emerge, but just being indoors. So I can certainly understand why a physician would say, you've had enough, just wait at this point, unless for some reason you perceive yourself at an extraordinarily high risk. And yes, where is this headed? I think it is heading toward an annual shot.
I went this morning, Marissa, for my own booster, over 65.
No, really?
and
You're over 65?
yeah, and it's been about 6 months since the last shot. And as the nurse was reciting the consent to me, you understand that this is an emergency authorization and you give consent to proceed. When are we going to be done saying this is an emergency authorization? Are we actually, I was thinking as she's reading this to me, this would be a reason for our questioner to say, okay, you'll let me know when it's not an emergency authorization, then I'm ready. Is how many times do I have to be told this is an emergency authorization? They told me the pandemic's over as of today, and you're still telling me it's an emergency authorization?
Right. Well, that's an excellent point. So the original vaccines, right, primary vaccination, are no longer under emergency use authorization, at least not Pfizer and Moderna, the original monovalent vaccines, right? They became approved. It all has to do with sufficient data. So the bivalent booster is still under an emergency authorization. It has to do with sufficient data to be brought forth to the FDA to meet the guidelines for approval as opposed for authorization. When we talked about vaccines early on, we looked at some of what is needed for emergency use authorization, and you need an emergency situation. And yes, that is evolving toward, as of today, we're no longer in that emergency use situation, but it's a limited amount of follow-up data. And to get an FDA approval, you need more data.
As you've been answering the question, one of our listeners, a chief medical officer, has typed in June, the FDA is going to hold a public hearing to address the recipe for the booster. Some people are saying it should be a monovalent vaccine directed against whatever the current present variant is. Wants to know your thoughts on that.
A monovalent vaccine for the current variant as opposed to a bivalent maintaining some of the ancestral strain. I think you have to really wait and see what they present as the data. What they did a year ago in a similar meeting was just looked at immune response, and this is all just laboratory immune response, right? It's not clinical. From the from the original vaccine that was only the ancestral strain versus the combined. So I don't know if they're going to look at a pure new, let's just say, taking only the Omicron strain as opposed to keeping the ancestral. There is a line of thought that ancestral immunity is very helpful, and that it may, in some studies, help with the how broad the immune response can be as new variants come up. So it's a very complicated immunologic question, and we're limited by the testing that can be done in an in vitro situation, and decisions have to be made from that. But I think what will go on in June will be very similar to what went on in June of 22 when they evaluated the bivalent booster.
Thank you, Marisa. Is Karen Murray back on?
Hi,
Karen.
Dr. Yes, I'm here. Sorry.
Why don't we give you another chance to finish the answer about the hormone replacement therapy? So I feel like we've fully answered the question. The question was about the issue of, do the risks really outweigh the benefits for hip fractures for hormone replacement therapy? And you froze in mid-thought there. So let's try again.
Sure. Thank you. Thank you for the question. As I started to state, the WHI did a randomized prospective study. They did 2 studies on postmenopausal women looking at hormone replacement therapy back in 2013 and 2014. And what they found was that the risk of cardiovascular disease and the risk of breast cancer was increased with continued use of hormone replacement therapy. They didn't actually address hip fractures in those particular studies. But what we've known is estrogen is the only thing that can promote bone growth. But there are other things that we can do to help to prevent bone fractures, such as increase in the amount of vitamin D, which will help to stabilize the bone, increase in calcium in our diet, taking raloxifene to help to decrease bone demineralization. So there are other things as well as weight-bearing exercises to increase our girth and strength and prevent us from falling. So those are the other things that they've suggested to help with the risk of fracture. But the thought was that the risk of breast cancer and cardiovascular disease outweighed the risk of taking hormone replacement therapy for the reasons of decrease in cardiovascular disease. And we didn't really know much about breast cancer at that point in time. So that's why they're recommending it for the shortest period of time.
Thank you, Karen. While we've got you, and before anything, any other gremlins attack your computer, we have someone who's typed in on the Q&A box regarding your remarks about menopause. Are postmenopausal fibroids common? And do fibroids in the postmenopausal woman need to be removed even if there's no bleeding?
Thank you for that question also. Postmenopausal fibroids are very common. Fibroids occur, they're actually stimulated by hormones such as estrogen. And once they're there, they usually don't disappear. They're usually there, they're structural, and are usually the only treatment is some type of surgical removal. Now, fibroids, if they're not causing symptoms, are fine to have. And we've seen in many women postmenopausal who continue to have fibroids that sometimes calcify, but they may shrink and they're still there. As long as they're not causing any problems, there's really no reason to remove them. The risk with fibroids occurs if you have a rapidly growing fibroid. There's a 1% chance of a leiomyosarcoma, but that is something that's usually seen in fibroids that are rapidly growing. So if you've had a fibroid that's stable or that's shrunk slightly since you've gone through menopause, there really is no reason to do any kind of surgical maneuvers
for those fibroids.
Yeah. Thank you, Karen.
Sure,
We're
thank you.
gonna turn our attention to Dr. Brown. The Q&A box is exploding, Dr. Brown, so make yourself comfortable here. One of our questioners writes, I'm not on city water, I'm on well water. Do I need to worry about this? And if so, how do I get my well water tested for these compounds?
Thank you so much, Dr. Halperin, and thank you for that question. That's a great question, and there is guidance from many professional societies. Myself, as a pediatrician, follows the guidance of the American Academy of Pediatrics that recommends annually that well water is tested. And this has been a recommendation for decades, long before these specific contaminants of concern, such as PFAS and PFOA. So it is a recommendation that well water be tested annually, and those testing recommendations are in line with the EPA, the Environmental Protection Agency testing. So I would recommend that testing is done annually for a variety of contaminants. As far as PFAS and PFOA, that would be included, and that can also be checked in the report. The report will be provided to the recipient of the private well water. To answer your question of how to obtain testing, so I would recommend looking on, in particular in Livingston, the state of New Jersey will have recommended sources for testing that is run through the state and verified by the EPA. There are private companies that can do that, but again, it should be a state certified lab. So the first step would be to look at the New Jersey Department of Health website for verified companies to get your private well water tested.
Okay, so you're looking for a government seal of approval that this lab actually can do what they claim.
Exactly.
Okay, well, related to let the consumer be wary, you recommended a filtration system. How do you know if the filtration system works? But more than there's plenty of people who will show up and say, sure, we'll install a water filtration system, but how's the consumer supposed to know if it's efficacious?
Absolutely, and that's a great question as well. So depending on the level of complexity of the filtration system, so let's start with the most simple. So for example, if you buy a Brita filter, and those are commonly purchased at a local convenience store, the assumption would be that the Brita filter is in fact working when you pour it into a cup of water. There is a way that you can actually test. They have certain testing strips for a variety of contaminants that are not PFAS specific, but you can do testing in your home. But my recommendation would be that you buy your Brita filter or pitcher filtration system from a reliable source. So you know where you're getting it from, you know that it's a legitimate Brita filter, you change the filter. That's one of the large recommendations that I didn't necessarily specify, is changing the filter is very important. But once it hits your cup or the device in which you're consuming your water from, you should be able to ensure by taking those measures that it is safe. Another thing you can do again is to install a system in your home, and these can be quite costly. There are seals of approval from the EPA regarding guidance on how to remove PFAS and PFOA from the water system. So I would make sure that if you are purchasing a device and installing it in your home, that it is EPA certified. With regards to having it installed in the company that you use, this would be similar to any other product that you install in your home, is really doing your homework to make sure that it's a trusted technician that's installing it, and being able to evaluate, again, after it comes out of the spigot and is used for your water consumption is very difficult. As I mentioned, there are ways in which you can test levels of contaminants and dissolved solids, but it's very limited in the PFAS space. And so it's really about trust in purchase of your consumer products or installation of these devices in your home, making decisions about EPA guidance as well. And that really is the equation for ensuring that you're an informed consumer of your water supply.
Thank you. We have a question in the same theme as the one that was asked to Dr. Goldberg. How come we don't know what the right level is of vitamin D. The questioner writes, you just told us that regulatory agencies change the level at which water companies have to report PFAS and PFOA. You didn't explain why they changed them or whose idea it was to change them and get us all worried about it. So they want to know, went from 100 down to 14, you said, in New Jersey. That's a big change. Where'd that come from to get us all upset about this and for me to invite you to come speak?
And that's a great question. And I completely understand that question and the concern. And we're living in an age in which we're learning more about this. And, you know, when I think about, for example, childhood lead poisoning or a contaminant in the environment, we learn more and more. And if you were to say to an individual in the community now that, you know, our lead level and our threshold for checking childhood lead used to be in the 20s. And that was the best that we could do. Now the tolerance for lead is 0, but when we check lead levels, state-based guidance is for a level less than 3 in the blood. So these levels come down and we learn more over time. And I think that's what we're seeing with the PFAS landscape. We're really living in a time where this is an active area of scientific investigation, and we are learning more and more about what an appropriate level should be. And so the drastic reduction is, and the testing that is being done and showing more positive results is really based on this reduction in overall testing and maximum contaminant levels. So in summary, there's a lot to learn, and we're learning it as we go. And this is what often happens in public health. But I think that the trust and the need for ongoing surveillance, for ongoing monitoring is very important in this space. And we will learn a drastic amount over the next several years and decades beyond what we knew in the past several years and decades prior.
Now, let's keep you with us for this next one. You said, Dr. Brown, that this PFAS and PFOA are ubiquitous now. So is it in the water they're irrigating the fruits and vegetables I eat? Is it in the rainwater? Even if the water supply is okay, how do I know my tomatoes, my corn, and my cucumbers are all right? Is this the stuff in everything that I'm eating now?
So that's a great question. And part of the story that I didn't get to tell, I talked a lot about detection, but on the policy side, the EPA recommended that PFAS chemicals be banned in the United States. And in 2007, that took place. So there is a great reduction of PFAS exposure to our population since 2007, when they were no longer manufactured in the United States. However, I did mention that they are called forever chemicals because, believe it or not, they will last for a very long time. And exposure from before 2007 is still an environmental concern. To answer your question about the fruit and vegetable supply, there are several things to think about. Whether this is contaminating our fruit and vegetable supply depends on a variety of factors. And it also depends on the type of fruit or vegetable. Certain fruits and vegetables will take in more water. And I'm sure many of you who are informed consumers of the food supply are aware of something we call the dirty dozen, or foods that take in more pesticides because, again, they are susceptible to contaminants in the environment. So the key is to really be an informed consumer of your food. If something takes up high levels of pesticides, it may take up high levels of other environmental contaminants, in particular PFAS. It doesn't mean that they are unsafe to consume. It's unclear what the level is, and it's unclear what level will interact with human health to cause certain health effects. So I understand that these health effects that we described are vague, but there are so many factors to consider with regards to consumption. I think the key message here is that fruits and vegetables are a part of a healthy diet. And so we wouldn't recommend that you limit or reduce exposure and intake of fruits and vegetables, but that you be an informed consumer of where your fruits and vegetables are coming from and that they're properly processed to reduce environmental exposures of PFAS or a variety of other concerns that are out there. Thank you.
Thank you. We're going to return Dr. Goldberg to the screen, please. Dr. Goldberg, we got a question that was typed in advance of the webinar. I was advised to take vitamin D as part of my treatment for osteoporosis. I think I had an allergic reaction to the vitamin D pills, itchiness from head to torso, but I didn't have a rash. Is there really such a thing as being allergic to vitamin D pills? If so, is it likely that it was a reaction to the vitamin D, or could it be something that's added to these pills? And if I really need vitamin D, what can I do instead? Is there such a thing as a vitamin D patch?
Well, thank you for that question. I'm not aware of allergy to vitamin D being a common occurrence, and I believe that the package inserts for vitamin D supplements do not include that as an adverse effect to notify the consumer about. Having said that, though, we hear about allergies to all kinds of things that may be uncommon, but are certainly real to the person who experiences them. And so I don't think it could be ruled out that this is a true allergy to the vitamin D supplement. Part of the question asked about the vitamin itself or the excipients or the additives, and my guess would be that any allergic reaction would be to the latter, not necessarily to the vitamin D molecule itself, but probably any of the number of excipients that are added to the tablets or the capsules or the gummies or whatever form you're receiving the vitamin D in. And that's certainly something that you will see listed on the labeling of the product that you bought. You can see what the inactive ingredients are, and you can discuss that with your provider and see if it makes sense to seek out a different supplement that has a different set of additives that you may not be sensitive to. In terms of other routes of vitamin D administration, the question was about a patch. I'm not aware of a transdermal application of vitamin D, but as I said, there are a variety of different oral formulations from tablets to capsules to gummies and liquids. And in fact, there's an intramuscular form of vitamin D that has been studied pretty thoroughly in the literature. And it turns out to be a fairly barbaric approach in that this is one of the intramuscular injections that, from what I've heard described, is on the far end of the painful side of the spectrum to receive. So not a very popular approach, but theoretically one that could be used in place of oral supplements if the need arose. So again, another very thought-provoking question. Thank you.
Thank you. Stay with us, and if Dr. Murray could come back on, please. You there, Karen? Well, while we're hoping that Karen, there we go. It looks like there's something happening. No, Dr. Murray disappeared. Okay, we're going to give you a break, Dr. Goldberg, until we get Dr. Murray back, because we've had a question typed in for the both of you, which means it's time for Let's Grill Marisa Montecalvo. Your fan club's here, Marisa. Dr. Montecalvo, if the significant protection from severe disease you just said lasts 4 months, how can you possibly say you're going to need a vaccine once a year?
Yeah, so perhaps I wasn't clear enough on that. It's at 4 to 6 months, we're seeing excellent efficacy still in the 90% range. That's very, very good. That means that, you know, as studies are coming out, even, you know, at 9 months and later, we are seeing ongoing efficacy against severe disease. It's just that all those studies are not out yet. But the high efficacy, that 80 to 90%, is clearly there at the 6 month range, and even probably a little bit further out that's been published.
Okay. We've got a couple more for you. How do you know how would I know if I got a bivalent vaccine?
So thank you. That's a good question. So everyone who is in the business of administering COVID vaccines gets, you're registered with the vaccine distribution center in the United States. You're constantly getting emails about changes. So when they said, okay, we're only going to use bivalent for primary or some other change that comes out. You know, your provider is receiving that information, but is it getting, you know, is it getting to the person who's giving you the shot, right? So I think there are several things that you can do. Number one, you are still given a sheet of information about the vaccine. When the vaccine is under emergency use authorization, as we talked about earlier, you receive a fact sheet as opposed to a vaccine information statement, which is only for approved vaccines, which currently we don't have. What's out there right now is all under emergency use authorization because it's the bivalent. So number one, you should be receiving written material that would be consistent. Number two, you should be receiving a record of vaccination. And I really want to stress this. You know, at the beginning, everyone had their CDC cards and was very careful about them. And I know from members of my own family who have been vaccinated that sometimes they walk out of a pharmacy, they don't have a written record of their vaccination. That is very important. And that written record will say bivalent, if that is what was administered, or it will say monovalent, or it should. And lastly, just, you know, I think it's always a good idea to ask. You can always say, this is the bivalent, correct? It's always a good idea to be an informed consumer, as you are.
The same questioner wants to know, do you recommend children 12 and over get a bivalent booster?
So I'm not a pediatrician, but it is recommended. Actually, the bivalent is currently recommended at 6 months of age and older. It's for all populations for whom the vaccine is authorized for use to have received a bivalent booster. Young children are on a bit of a different schedule. They may need more than one vaccine, but you know, I think it's the same situation. It's that you want to, you know, do your best to keep your immunity up within reason, given overall what your lifestyle is like. But in terms of the nuances of whether an individual child should be vaccinated, that's really outside of my area.
Okay. Let's bring Dr. Goldberg back on. Thank you, Marisa.
Thank you.
Looks like we're going to have you go solo on this one since Karen Murray's computer seems to be knocked out. We've got a mixed internal medicine hormone replacement question. Postmenopausal women are by definition older. The incidence of hypertension goes up as we get older. In someone who's hypertensive, is it reasonable to continue to consider hormone replacement therapy, even if given in the short run in the management of hypertension?
Yeah, that's an interesting angle to this question that we've been discussing. And I may not have a whole lot more to add to what Dr. Murray outlined in terms of the current recommendations. And this goes for the endocrinologists as well as the gynecologists in terms of the exposure to menopausal hormone replacement therapy being the lowest effective dose for the shortest period of time. And I think here again, it's another example of where the risks and benefits need to be weighed carefully. And my guess would be, and I would be curious to hear the gynecologist's perspective, of course, that the other ways that we can prevent and or treat hypertension may be safer, or the risk-benefit ratio may be more favorable to that we would see with hormone replacement and the attendant risks that Dr. Murray outlined. So in terms of, again, looking at just the angle of hypertension management, I'm not sure it would change my personal adherence to those general recommendations about the limited use of HRT. Thank you very much.
Thank you, Dr. Goldberg. Dr. Brown, we're going to give you the last word. The citizens of Livingston aren't done typing in questions, Dr. Brown. So they got a fastball for you for the last question.
Okay.
shouldn't the companies that made these chemicals be bearing the cost of remediating them? Why do I have to go out and buy a water filtration system? It's not my fault that they're all over the place. I didn't ask for this in my water supply. Shouldn't somebody be suing somebody or some governmental action to make the people who did this to us responsible?
Thank you for that question. It's a great question, and I feel the same, and I think the public feels the same as well. I would recommend, well, first, let me say that since 2005, there have been many lawsuits filed. Some of the biggest producers include 3M and DuPont, and we are talking about millions and billion-dollar settlements. And you can follow this all. There's plenty of information about PFAS litigation. In particular, what we've seen over the past few years is that not only are these the large manufacturers, but there's even lawsuits against companies like Burger King or McDonald's who use PFAS in their food packaging. So we're seeing it come out even more in consumer products as opposed to some of the larger manufacturers. There are great documentaries on this. One of them is called The Devil We Know, that was produced in 2018. And that really goes over the history beyond what I was able to present in the short presentation of PFAS chemicals in the United States, in the population, and where the landscape is. That was as of 2018. And as I mentioned, this is a very rapidly evolving field. But to answer your question, we do as consumers of our food supply, of our water supply, of our personal care products, we do bear the brunt of these effects. However, it is an active area of legal investigation and ongoing concern. And I would recommend that everyone who's interested in learning more look for these resources that are in the media and available for the public. Thank you for that question.
Well, thank you. If all our panelists could come back on, I want to thank all of our panelists for joining us this afternoon. I want to thank the audience for their excellent questions. As usual, the hour and a half has flown by. Thanks for joining us. We'll see you again in about 6 to 8 weeks. If you have suggestions for topics in the future, please be sure to send them to us in the emails which you have used to send in your questions. We wish everybody a good afternoon and thanks for joining us. Have a good afternoon, everyone. Bye-bye.